infectious and inflammatory diseases. Okay, so this is, we'll talk about meningitis, right? If you know what the meninges are, the coverings around the brain and spinal cord, well, anything can get infected. So the meninges is one of those things. The most common cause is an infection. Bacteria, viruses, fungi can cause this. It's difficult to treat and can become fatal. That's why we need to talk about this one. Epidemics can occur. Now, it depends on the age group. So what I want you to know is the most common things. Okay? So it depends. MO is the most common, or let's say the microorganism, right? We talked about that when we did infections. So microorganism type varies with age group. It depends. All right? They have a lot of different ones here. These are the ones you should know. In other words, newborns, the most common cause of meningitis is E. coli. In toddlers, you're looking at Haemophilus influenza. In adults, it's strep pneumonia. Okay? This is the one that we got to also keep in mind for both you, because of where you're sitting at right now, the dormitories, but you have adults in the college or military. It's Neisseria meningitis, and that's deadly. All right? These are the ones that actually will cause those epidemics. So because of that, I want to talk a little bit more about that one. Okay? No problem. And it'll be up in the field. Okay? So, meningococcal meningitis. That's the Neisseria gonorrhea one. All right? 33% have Neisseria that's in the back of. Now, I'm not saying Neisseria gonorrhea. Okay? That's a sexually transmitted disease. This is Neisseria meningitis, which is still in the same family, right? Same family, but different. And 33% of people have this as normal flora in the back of their throat. And it doesn't harm them at all. Their body's doing wonderful with it. It's no problem, okay? That symbiosis that's going on. College dormitory, military living people, this is where they're most prone of getting this area because you're such in close quarters. These are the ones that will cause the epidemic meningitis that you hear about. They're closing down schools and things like that, colleges. Okay? It's deadly. It'll go into the brain, go to the blood, cause septicemia, shock, and death. All right? It's done by air droplets. Cough on someone, sneeze on someone. That's how people get it, because it's in the back of their throat, and it can cause someone who's going to be susceptible. So those are the ones you should know. Again, going back to this one over here, you should know the most common ones. There's a whole list, but I think if you could go with this, these are the kinds of questions that we ask on NCLEX, the most common ones. Okay? All right? Viral meningitis. Now, what we just talked about was all those causes, E. coli, Neisseria, they're all bacteria. Those are the ones we have to worry about. Viral meningitis, luckily, this is the one that's not so bad. We sometimes refer to it as aseptic meningitis because when we do a lumbar puncture, when we draw some of the cerebral spinal fluid, that there's no bacteria in there. So sometimes they refer to it as aseptic meningitis. Which brings up the whole thing about lumbar punctures. If you have somebody with meningitis and you think they have intracranial or increased intracranial pressure, are you going to do a lumbar puncture? No. You're going to have to rely on your diagnostic skills because you're not going to put a needle in their back because you don't want part of their spinal cord to come out also. So that's why you should know what causes increased intracranial pressure. Okay? These are the more common viruses that would cause that. Echovirus, Coxsackie, enterovirus would actually cause these things. But it's, like I said, it's much less severe than bacterial meningitis. Luckily, the treatment for something like this is just supportive. They don't need to be in the hospital. They may if they get fevers that are just too high. But yeah, this is more of a supportive thing. There's no antibiotics for something like this. Okay? Signs and symptoms of meningitis overall. All right? Look at the usual fever, headache, nausea, and vomiting. Okay? If a lumbar puncture is performed, you'll also see certain changes in there. Right? You got the bacteria stuff. You had that?
No, I work in the ED at Children's, so we do LPs on babies.
It's sad. I mean, you put in these needles. That's why I didn't want to do pediatrics.
Then they look to see like how cloudy they are and like
with all that stuff. Now, certain things you'll look at is nuchal rigidity. These are more, again, when you read a case study, when you read a paragraph, you're looking for key words. right? That's why I said it's okay for you to bring your highlighters to the exams and stuff. Key words, you see words like nuchal rigidity. Nuchal rigidity, was that? In the first chapter. Because was it the first chapter? Or the third? With infections. It could have been the first chapter.
It was the first because it was talking about that the baby and they thought she had the flu and then she came back and she had meningitis.
Okay. Yeah, it was the first one. But what happens here is they get nuchal rigidity. Nuchal rigidity is that you get pain when you bend your neck down. So you have to think meningitis is inflammation of the meninges. So you have this meninges that's getting thicker, it's getting inflamed, and it's irritated. So when you bend your neck down, you're taking that, which means you're going to irritate that. So these are people that they don't want to look down. If you ask them, you know, did you tie your shoe? I don't want to look down. Those kinds of things on there, why don't you want to look down? It hurts over here. Now, don't get me wrong. You can just sleep the wrong way and have that, but you're not going to have a fever, you're not going to be nausea and vomiting, you know, you're not going to have these other things. Also, too, photophobia. You walk in to see a patient, right, in the waiting room, let's say a doctor's office. She's coming in because of headaches. You go in there, and it looks like that. You turn on the light, and she's like, whoa, whoa, turn it down, it hurts my eyes. You're putting things in together there. Bright lights hurt you, photophobia. You ask her to look down at her shoelaces, it hurts her neck. Got a fever. You're putting all this together. I'm not saying it is meningitis, but you better darn right rule that out. Because again, if you have this meningococcal one that can start a whole epidemic, you might have the start of the case right here. All right? So it's seeing those little things. And again, how do you treat this? It's usually antibiotics, and you got to do it fast. Okay? So that's what that is. All right? Encephalitis, usually due to a virus. Not all the time. There's toxoplasmosis, which is an infection that comes from a cat, especially if you're pregnant. But most cases, it's due to HSV, this herpes simplex, cytomegalovirus, arboviruses. This is actually the chickenpox virus, varicella zoster virus, which technically is a part of. I mean, there's 6 different herpes viruses, and chickenpox is part of that also. I forgot what type it is. So this is where you have inflammation of the brain parenchyma. So what's happening, and it's better when you look on the screen itself, but in the white matter, so this is the brain, of course. Here in the white matter, you'll see these little red dots scattered all over here. Those red dots are blood vessels that were dilated because of all this inflammation that's going on, right? That's your 5 cardinal signs, right? You get dilation, becomes red. So that's what's happening over here. You could also see even the gray matter is very red too. All right. So you're going to see a lot of obviously to do something like this, you're going to have to do an autopsy, but we hope we don't have to do that to that point. But anyway, that's what encephalitis is when the brain itself is infected. Okay. Now. Corticospinal Tract, okay? Hoping you guys did this before, because I took all these from my other PowerPoint AP1. Corticospinal Tract is going to explain things like, if you had a stroke on this side, and we're not talking about stroke now, but just so you understand, if you had a stroke of your brain on your right side, you won't be able to move your contralateral side. The part of your right side of the brain is going to control movement on the left side, and vice versa. Reason why is because it crosses over. And the tract that does this, the descending tract, the motor tract that does this, is called the cortical spinal, because it goes from the cortex of the brain, cortical, to the spine, cortical spinal tract. Okay? And this eventually is going to, so it starts off in the frontal lobe, goes down, and this area here is going to be the brainstem. It crosses over at the brainstem and then travels down in the opposite side of the spinal cord that it originally came on. Then it synapses at wherever it's going to go out of. It synapses in the spinal cord in the gray matter, specifically the anterior horn or the ventral horn, same thing, okay? When that happens, it's going to synapse with another neuron, and that's going to go out to whatever skeletal muscle that goes out to. So in this case, we have two neurons. So this is a two-neuron pathway. There's one we call the upper motor neuron, and then where it synapses, it's going to be having the lower motor neuron. All right? The ones going up, there's three neurons, and I'm not going to go into that to explain all that. But this one is not too bad. So again, it begins in the frontal lobe as an upper motor neuron. Okay? It'll travel and cross over at the brainstem to the other side. And then continues downward the spinal cord to wherever it's supposed to go. If your brain is trying to tell your arm to move, then it comes out of that part there. If it's going to tell my leg to move, well then it's going to come out that way. It's going to go a little bit lower. Wherever it's going to go, whatever level that is. And then it's going to synapse with the lower motor neuron at the anterior or ventral great horn, and then that's going to go out to the skeletal muscle. Okay? So this is all motor neurons. This is all efferent pathways. This is all descending. This is all going to tell the skeletal muscle what to do. Okay? Clear with that? And there's an upper motor neuron and a lower motor neuron. Let's talk about polio. Polio, okay, we don't see it much now. However, because we have the vaccines, but we do have people who are elderly who got polio when they were little. So you still see it. You're just not seeing people getting new cases of it. You will see it as a nurse. So it's due to the polio virus, and in some other countries it does spread because they can't get the vaccines. It does spread through fecal matter, water. It destroys the motor neurons only in the anterior horn of the spinal cord. So what's happening? Let me go back to this. It destroys this right here. So the lower motor neuron gets destroyed. Not the upper motor, but the lower motor. Okay? So what happens here is they will, well, let me ask you this. We've been talking about this. So if a person's got polio, okay, and they can't move their arm, usually their legs, but it could be their arms too. Well, let's say they can't move their arms. So here you are as a nurse. This is teaching you bedside manners, and it's very difficult to teach bedside manners, but you can understand this. He can't move his arms, okay? So you're thinking as a nurse, he can't move his arms, so what is it if I hold on to his hand? Is he going to be, can he move his arm? Can he, if this was the affected arm, can he move his arm? No. Can he feel something there? If a fly lands on there, can he feel it? He can feel something. Keep in mind, this thing here is only motor. It's only affecting motor. It's not affecting things going up. So sensory is intact. Yes. So if you see someone who can't move, do not assume that they can't feel. And this is where bedside comes in. You know that they have polio. You're going to want to hold their hand. Just because they can't squeeze back does not mean they don't feel the comfort of your hand. Hold them and squeeze and say, I'm here for you. That's what matters. That's bedside stuff. Because you understand pathophysiology. At times you'll be thinking about me at those bedside. Because it's very hard to teach bedside manners. Yeah, I just look at people, whether nurses or doctors, and I say, I want to be able to do that over there. Or I'll say, I definitely don't want to do that. This has made the patient very embarrassed. So it's kind of like you just learn it by just watching. But there are certain things. Understand that they feel they can't move. They won't squeeze back. So they feel the fly there. They can't swat it away. All right? You see how you're putting this together? Right? Understand that. Okay? They usually die, unfortunately, because the the rest of the diaphragm gets affected, and then they won't be able gets affected, and they won't be able to breathe, and that's what they usually die of.
Is that an enterovirus? I think polio is an enterovirus.
Is it?
That's what I remember hearing. Because
I have to look back on that. I'm not too
that
sure.
new enterovirus that's out that's affecting kids, it's got the GI component to it, and we've had a couple of EMAS that are like having flaccid reactions after the enterovirus. And I remember one of the doctors saying that polio was an enterovirus. So they don't know if this new enterovirus has some type of a polio type component.
It could be because I have to look. I have to look up, but it can be because it's for fecal matter. So it goes down into your GI tract. And enteroviruses are a group of viruses that are affecting the entero, meaning like the gastrointestinal areas. So I'm wondering if that falls into the. I'll look it up. I'll look it up.
These kids are having side effects like this.
I wonder if it's a variant of polio.
It's kind of scary.
Yeah.
How it's been happening. It happened at UMass. A couple of kids have come in with it. They had a sickness, which they.
And they're just calling it enterovirus at this point?
It's got a specific name. It's got a number to it.
Oh, yeah,
Enterovirus.
H1, yeah, those.
It's got a number to it, but it's correlated with this paralysis and flaccid weakness that these kids get. And it can last a couple of months. Most of them do. Some of them have not.
Yeah.
And some have gone to respiratory arrest.
Yeah,
So they don't know if they're on the brink of a new
Mm-hmm.
polio, which scares the crap out of me. So it's like,
Yeah.
it's
And I
terrible.
assume that they had the vaccine for the polio.
Yeah, oh God, yes.
Yeah.
Oh, yeah.
You can't go to school without it.
Right.
And that's still in Pakistan.
Oh, yeah, they're still,
It's still
because they can't get
really-
the vaccines there.
Yeah.
Yeah. So, I'll look that up. I'm not too sure. That's interesting.
They haven't-
But unfortunately, they give you those little numbers. The
Yeah.
swine virus was in swine, or the flu virus, or the avian virus. Yeah, they got these little numbers and stuff.
I had a friend in high school who just like woke up one morning and they were like saying,
Was it this, polio?
wait, what? But then she like regained.
I think that might be Guillain-Barré syndrome,
Yeah.
which we'll talk about. Which we will talk about. How old was she? Yeah, they fit to. Yeah. We'll talk about that one. Not today, but we'll talk about Guillain-Barré syndrome. 'Cause that's what that sounds like. You know, just woken up and just happens like that. Yeah, yeah, yeah. So that's polio. Polio, all right? And who's this guy here? No. No. FDR, yeah. This is the reason why. Yeah. Yeah. This is Social Security. He did all the New Deal stuff, right?
It's amazing, yeah, because didn't he, like, when he at the podium, he would, like, he had, like, special.
He had this as a
You
child.
couldn't actually tell, he had it.
Yeah.
Hide it. Oh,
Yeah.
He didn't have, when he was it got, I think it got worse, but he actually had the wheelchair even during the campaign.
But he would hide it.
Trying to, yeah, I mean, he would hide it, but you knew that the wheelchair was there,
Cool.
yeah.
It's cool if you were watching speeches,
Yeah.
like, watching.
Yeah, it's speeches, you can actually see that on there. I was surprised that they had a video, you can actually listen to it, him speaking. It's, I didn't think we had that much technology at that point, but yeah. So, but yeah, that's FDR. Okay, so this is the last one I want to just talk about. And this is the chicken pox, right? So what's happening here, so let me explain what's going on. This is the herpes virus. Okay, there's like 6 different herpes viruses. The varicella refers to the chicken pox. The zoster refers to shingles, okay? So this is what happens with chicken pox. You get the chicken pox or the chicken pox vaccine, all right? So you've been exposed to the chicken pox. But you have such a good immune system, you're able to take it down. And you would think that it goes away from your body. It doesn't. What it does, it finds a nice little hideout called the dorsal root ganglion. And it hides there for decades. So viruses, the other thing in rule of thumb is viruses you don't lose. They always will stay with you, like HIV, herpes. I mean, they usually tend to stay with you, okay? Not all the time, but usually. So you have this chickenpox virus, the varicella, that gets scared because the immune system is so great. So it finds a place. Now, which dorsal root ganglion in the spinal cord does it go to? We don't know. It just randomly picks one spot, and that's important. So it picks one spot and stays there. And it stays there for years, decades, until your immune system goes down. And that's why I need you to know different reasons that will make your immune system go down. Whether HIV, corticosteroids, when you become elderly, all these things will make your immune system go down. Stress too. My course will make you have your immune system go down. You will see you get sick during my class. All right, that's okay. All right, but that's what happens. Now, when your immune system goes down, now this is the thing that's really interesting. When your immune system goes down, the sleeping giant that was in your dorsal root ganglion awakens. And what it does is that it's going to go down. Now, if you read my first 38 slides, the dermatome map. Now, I'm not asking you to memorize that, but understand the concept. It's areas of the body on the skin that has sensory that goes with certain particular levels of the spinal cord. I'll show you what I mean by that. And what happens is this virus will follow that dermatome, and it's going to create a rash that fits perfectly with that dermatome. You've got this band that happens here. It's a very distinctive rash, and I'll show you what that looks like. So again, everything I just explained, it sits in a dorsal root ganglion. Okay, once the patient is exposed, reactivation happens with immunocompromised patients, stress, infection, surgery, elderly, HIV, a whole list of different things. But then it's going to appear, this new rash from this virus that is now awakened is going to then appear on this dermatome. And it's so nicely delineated. I'll show you the pictures on there. But it's not itchy like chickenpox. Sometimes it can be, but most of the time it's extremely painful. So these are different dermatomes. You do not have to memorize all the different dermatomes. It's not about that. It's understanding that our bodies is situated in a way that you can actually, if I touch here at the T12 level, then I know that sensory coming out of T12 of the spinal cord works. It helps us to map out where the lesion in the spinal cord is or isn't. What happens here, you see how like these little bands, well, you got one side over here and another side over here. So they get these bands, you won't get all the bands on the same person, but you get this wonderful band on one side like this. See this band that happens up there. The band. It's such a classic thing. It looks like chickenpox, has those vesicles, but very painful. Now sometimes, this can be really bad, when you have, let's say, even your cranial nerve number 5, you have 3 branches that come off, V1, V2, V3. They can actually sit at where the cell bodies are of each one of those branches, and it can actually infect that and give you that rash in a certain area there. So what happens, see that wonderful band? Look at this. This is so beautiful. Well, it's not beautiful, but the rash is so like, I know exactly what it is. It's such a delineated thing over here. And this is actually in V1 of that. That's where it was sitting. And it goes out into that area.
Can it cause permanent damage?
It can. It can scarring. It can cause scarring. Usually it's self-limiting, and it'll go away. But something like this, it can cause blind. I mean, this is a severe case. This is really severe. This usually not. You know, you just deal with it, and they give you some medication to deal with the pain, but it usually goes away in a few weeks. Okay, so that's what happens with it. I think that's this wonderful band over here. Yeah, it's still pain. Really quick. Bell's palsy. Bell's palsy is paralysis of one side of the face due to inflammation of the cranial nerve 7. If you remember what cranial nerve 7 does, it does movement of all your facial muscles. So what happens here is that you have a nerve that's, either infected or something's inflaming it, some other disease or something. Usually, it's going to compress that, and therefore, on one side of your face that it's where it's affecting, you're not going to be able to move that face, or that side of the face. And I'll show you what I mean by that. Luckily, and these are the ones you should know, it usually resolves in 4 to 6 weeks. This is more like, it's scary at first. They can't move one side of their face. What are you thinking if you can't move one side of your face? Stroke. But this, if you could figure out it's just this, you could reassure the patient, this is what it is, you'll probably get better in 4 to 6 weeks. So here, he's trying to raise his eyebrows. But he can't do that on this side. This one is beautiful, you can move it up. You could also ask him to close his eyes really tightly and smile. Well, he could close his eyes tightly here and smile, but on this side, he can't close his eye and he can't smile. So that is Bell's palsy on there. They got to rule out stroke. And we had good old George Clooney at sixth grade. He had that crooked smile. He was made fun of a kid, but I think he got over it because of where he is now.